We'll move to Dr.
Dr. Khaled abdellaal from MRCS. He's going to speak about retroperitoneal approach for aortic aneurysm.
Good afternoon, everyone. Thank you, Mr. Chairman, for your kind invitation. I know it's very difficult to speak about open surgery in the era of endovascular techniques for the aorta, especially in such international meeting. But I insisted to uncover the dust from a forgotten technique that I described as very important in our vascular armamentarium, especially for young physicians. So the endovascular technique, the retroperitoneal techniques, it's a vast majority of incisions and a big family of exposures. It has been started first in 1963 by Charles. Well, I'll try again. Now, 1963, these techniques were first described by Charles Robs, who was the first to publish a series of more than 500 procedures by these techniques. A few years later, this technique was developed by Williams, and we found that it facilitated the exposure of the proximal aorta and visceral branches. And recent reports appreciate the physiologic, anatomic, technical advantage of the retroperitoneal approach. And the indication later on was expanded for repair of all types of aortoiliac disease. So when you can see on the right side, the Rob's classic technique between the tip of the 12th rib up to 2 fingers below the umbilicus, and then it was expanded later on by Williams by the pararectus technique, and expanded downwards to the lombotomy up to the thoracoferral lombotomy that you see on the left side. So when I started to study this subject on literature, I started to search first for the disadvantages of retroperitoneal technique. And I found some anecdotal criticism. First, it has a learning curve and can appear less attractive. Of course, this is not a criticism because everything needs a learning curve. But the abdominal contents cannot be assessed, and the venous anomalies such as retroaortic and renal vein of left side, inferior vena cava, also cannot be assessed. But also these are very rare conditions, and they can be appreciated just before surgery during the angiographic workout. So these are not a serious condition. But the most acceptable one was published by Honing and Gardner, who state that there is incidence of bulge. Although it is a small notification, but a bulge means a kind of hernia. In their study was between 11 and 23%. And they thought that it is associated with abdominal wall nerve injury. 4 years later, Nakajima has published another similar study stating that there is no direct evidence of such hernia, and he found even when he compared the retroperitoneal or transperitoneal that the hernia are more in the transperitoneal approach rather than the retroperitoneal. So when we come to the advantages of the retroperitoneal, we found that it provides an unparalleled access to the abdominal wall and supraceliac level, the left renal artery, and even both iliac arteries. The technical challenge that we may face in transperitoneal approach can be avoided, as in case of hostile abdomen from multiple laparotomy, several adhesions, or even after left side colonic surgery. In obese patients, this technique is very advantageous because abdominal fat will fall to the right side because the patient is tilted on his right side, and the fatty omentum and bowel are completely avoided. Even some cases with stromas after cancer colon can not be contaminating to the wound because they are not in contact of the incision. Another technical challenge that can be avoided by the retroperitoneal approach was described by Calco regarding the importance of this technique in high-risk patients for open surgery, often with significant cardiac or respiratory comorbidity. A horseshoe kidney can be avoided by this technique, and they have found that it has easier access to the juxtarenal, suprarenal aorta for aneurysm when placement of infrarenal aortic cross clamp is not possible. This is also very important to adopt this technique in case of inflammatory aneurysm, fibrosis, and in case of redo aortic surgery after previous transperitoneal. It decreases the post-operative ileus, less respiratory complication, better toleration for the incisional pain, and decrease of hospital stay. Regarding the results and the outcome, it was managed by Arco and Hayuki and published in 2001-2002, and they have found that the operative mortality in retroperitoneal approach was about 12% and compared to 34% in patients with transperitoneal approach. That means the retroperitoneal approach in case of aortic aneurysm in these cases was less 3 times than the mortality complication transperitoneal approach. They have faster recovery, quicker return of bowel function, fewer pulmonary complication, less pain, and less cost. And they found that the possible reason for better outcome were reduced blood loss, loss of drop of temperature due to lack of peritoneal opening, and earlier return of gastrointestinal function. Studies comparing retroperitoneal to transperitoneal was started by Sikar in 1987 when he evaluated the retroperitoneal approach against the transperitoneal in a retrospective non-randomized study containing both stenotic and aneurysmal aortic disease. He concluded that the retroperitoneal approach was preferable with less blood loss, faster initiation of oral feeding, and reduced hospital stay. Few years later, Darling has confirmed this data by a prospective study published in 1992, but only with 27 patients. Sikard published again 3 years later, 1995, a real large prospective randomized study reporting 75 patients operating by TP group, TP technique, and 70 in retroperitoneal technique, and he found fewer complications and shorter intensive care. Even the recent study in 2010 by Bocon has performed the retrospective study concluding the operative time was longer in transperitoneal group, and there is a quicker return to gastrointestinal function in retroperitoneal group, and interestingly, fewer incisional hernia occurred in the retroperitoneal group. So now, in the era of endovascular, transperitoneal, retroperitoneal, Baldrige tried it in 25 years ago, in 1999, to answer this question, which technique to adopt. By this time, endovascular, of course, was not developed as today, but he concluded that there is no difference in mortality rate. Endovascular is much better because it has shorter stay and less morbidity. But he concluded and confirmed that the retroperitoneal approach has less complication and less cost compared to transperitoneal approach. So when I searched now for the publication in the literature about endovascular repair compared to retroperitoneal surgery, I did not find any single prospective randomized study comparing endovascular repair with the retroperitoneal approach. No study has even directly compared the fenestrated graft with open revascularization of visceral arteries or renal arteries by open technique. And the current recommendation based on prospective registries still suggest open surgery for low and mild moderate risk, and for fenestrated devices are reserved for the moderate and high risk patients. But of course, as devices and experience improve, the debate between fenestrated grafting and open surgery looks to be continued. So, is there some conditions that open repair are recommended than endovascular techniques? Of course, the endovascular techniques now is the gold standard, but some conditions where the gold standard cannot be applied, like in case of some anatomical consideration, like severe tortuosity, extensive calcification, or inadequate landing zone, like in case of complex aortic pathology, as in aortic dissection requiring concomitant procedure like coronary artery bypass or grafting, in case of infected aortic aneurysm, aortoenteric fistula, where open debridement may be necessary. Sometimes also open surgical repair may provide more durable result in certain patients, particularly in young individuals, those with connective tissue disorders or recurrent aortic disease. And finally, some emergency situations like unstable patients, acute aortic dissection with complications such as malperfusion or rupture in case of non-availability on the vascular graft. So to conclude, we confirm that EVAR will remain the gold standard for a long time, but please consider that the retroperitoneal approach proved to have less operative complication and mortality rate compared to transperitoneal approach. It showed faster return of gut function, less blood loss, less intensive care stay, and early improvement of respiratory function. It may be more useful in presence of renal, suprarenal, visceral artery, and complicated aortic disease. So in our recommendation, retroperitoneal approach should be routinely replacing the transperitoneal approach in case of occlusive aortic disease or aortic aneurysm when the endovascular options are not available. And it is very essential for the treating physician to carefully evaluate each patient characteristic, including health status, aortic anatomy, specific aortic pathology, to determine the most appropriate treatment approach. Before saying thank you, I want to invite you all to our third International Congress, which will be held in Abu Dhabi next February. and I'm responsible for the peripheral track. So if you have any presentation to give, please scan this code and send me the presentation personally. We'll be glad to receive your talks. Thank you very much and wish you a successful Congress.